Welcome to the Southwest Affiliate Stroke Bootcamp series. We are excited to offer this 15-week course as a way to educate the stroke coordinators in key components of their role, provide tools and resources to build and maintain successful programs, and to assist in building a large network of peers. Now, before we get started, we would like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type in the Q&A section of WebEx. Please note you will only be able to claim your CME CE credit at the end of the 15-week series on September 27th. Excuse me. A copy of today's slides and any handouts will be sent to you within a week of today's call. For future webinar offerings, including the Stroke Bootcamp webinars, please visit www.heart.org/SWA quality. Excuse me. Now we will begin today's webinar. Jamie has over 17 years experience in the emergency and flight nursing. She has worked with numerous EMS agencies and has the role of the EMS coordinator for the last 9 years. In 2009, she took the role as a stroke coordinator at Baylor Scott & White Grapevine and led her facility in becoming a certified primary stroke center. She has presented locally and nationally on caring for strokes. She also organized getting the North Texas stroke coordinators together in supporting stroke awareness in their communities. Currently, Jamie remains active as a stroke program coordinator and is working on her facility becoming a comprehensive stroke center for the North DFW area. We also have Michelle, is certified as a stroke care registered nurse by the American Board of Neuroscience Nursing. She began working with stroke programs in 2008 as the first primary stroke program manager for Methodist Hospital and was instrumental in primary stroke certification for the Methodist healthcare system. She became part of the Baptist healthcare system in December of 2015 and was instrumental in the achievement of comprehensive stroke certification at St. Luke's Baptist Hospital in 2016, the first comprehensive stroke center in San Antonio and South Texas. She continues to serve in this role and actively participates as a member of the STRAC Stroke Committee to improve stroke care in the region. I will now turn it over to Jamie and Michelle.
Thank you. Good morning, everyone. It doesn't seem possible it's already August. It seems like we just started the boot camp series. I know I've learned a lot from the different types of topics that everyone's presented. So today, Michelle and I are going to be talking about how you can make patient transfers a safe passage from our place to yours. Whether you're a new stroke coordinator, a seasoned stroke coordinator, or getting ready for a survey, it's important for you to establish transfer guidelines. This allows a smooth transition, which ultimately leads to improved patient outcomes. If you've been through a few surveys, you know they tend to come up with a theme in the types of things they are looking for. It seems like right now patient transfers are a hot topic. So hopefully today you will learn some tips on how you can provide a safe passage for our patients. Michelle and I have no disclosures. And some of the objectives that we're going to be reviewing today are about the clinical practice guidelines for the systems of stroke care. We're going to discuss acute stroke treatment and emergency stroke evaluation, transferring of patients who have received alteplase or TPA, and also those that may be going for endovascular reperfusion. And then we're going to look at some recommendations from the sending facility and the receiving facility, as well as with the transferring agency. We're going to look at measures to improve systems of stroke care, and then also look at next steps for systems of stroke care. So everyone knows that stroke is the leading cause of permanent disability, death, and cost in the United States. Every 40 seconds, someone in the U.S. has a stroke. Approximately 800,000 people experience a stroke annually, and $72 billion are spent annually directly on stroke care expenses. So when you look at the statistics, it's important to keep in mind that the number of people affected and what we do makes a difference in their life. So stroke happens fast, and we all know that for the ischemic stroke, it accounts for about 80% of all strokes. This is about 640,000 people. Approximately 280,000 of these are due to large vessel occlusions. 20% are due to large vessel atherosclerosis, and 20% are due to cardiogenic embolism. So what I thought was pretty neat is I did the math. I took this and I figured out that that's about 40% of our ischemic stroke population are large vessel occlusions. So it might be interesting for you to go back and look at your stroke numbers and see, are you in that 40% where you're receiving this type of large vessel occlusion, or is there some work that we can be doing out in our communities to achieve that? On your hemorrhagic stroke, which is about 20% of all strokes, you have your intracerebral hemorrhages due to hypertension or anticoagulant use, and the subarachnoid hemorrhages due to aneurysmal rupture.
Great. So that review is very important for us to look at because acute stroke treatment depends on stroke type and is time sensitive, making it more important that stroke teams understand the cause and also the origin of disease in order to develop the appropriate skills that are necessary for us to care for the different types of stroke patients. So we do need to be aware of what does your stroke area or your stroke population look like. And we do know that as you're preparing for surveys that your HR files will be reviewed to make sure that the required stroke education has been provided. So you want to be sure that your staff is receiving the appropriate education and that you're focusing on your appropriate stroke population. So acute stroke treatment algorithms must also be evidence-based, and they must be up-to-date. So we have to be sure that we are keeping up-to-date with all of the rapid changes that are going on with our clinical practice guidelines, because they will be definitely reviewed to make sure that we are aligning our protocols and algorithms with clinical practice guidelines, recommendations, and or policy statements that are utilized for our program. And these guidelines must be available to our stroke team. So we must ensure that our stroke teams are aware of which guidelines we're using and also where these guidelines are so that they can locate them and review them if necessary. So for our ischemic stroke population, our nurses are responsible for IV TPA administration without delay. We want to make sure that they're aware of our goals within 45 to 60 minutes and should be administered in less than 3 hours and never more than 4.5 hours from time last known well. And nurses must also be familiar with the criteria for endovascular reperfusion in order to expedite triage so that mechanical intervention can be performed as quickly as possible within and up to 24 hours in select patients. And both of these have been shown to reduce disability and cost of stroke. So that's extremely important for us to reinforce with our stroke teams because every goal affects each and every other goal that is going to come into play when we start to move these patients and transfer these patients. Now, we'll be focusing a lot on the ischemic stroke transfers today, but we also do not want to forget about our intracranial hemorrhage and subarachnoid hemorrhage patients. Our stroke teams must be familiar with blood pressure goals for each stroke type in order to anticipate the initiation of treatment and also to maintain pressures at desired goals. So elevated systolic blood pressures are associated with greater hematoma expansion, neurologic deterioration, death and dependency after intracranial hemorrhage, making blood pressure management to target pressures of less than 140 critical, and our nurses must be familiar with reversal protocols and also strategies for the administration of reversal agents. Factors with aneurysm rebleeding include systolic blood pressure of greater than 160. So for our subarachnoid hemorrhage patients, blood pressure management to target pressures of less than 160 and diastolic less than 140 is also going to be critical. So we need to make sure that our teams are on board with that. So regardless of stroke type, you can go ahead and go to the next slide now, Jamie. Systems must be developed to achieve minimum delay from symptom onset to definitive treatment. And regional systems of care require healthcare facilities that provide initial emergency care. This includes the administration of IV TPA, and then also centers that perform endovascular treatment, which requires rapid transport when appropriate. And we do know that benefits of both IV alteplase and mechanical thrombectomy are time dependent. So our stroke protocols, you can go ahead and go to the next slide. So stroke protocols must include simultaneous evaluation for IV alteplase and mechanical thrombectomy. And I think as coordinators, that is our biggest challenge when we are working with our acute stroke teams. And so we do have some stroke care management flow sheets that we can utilize in our ED areas to ensure that our teams are not thinking about TPA and then thinking about mechanical thrombectomy, but they are thinking about both of these treatments simultaneously. So in order to select and expedite triage, there are multiple tools to screen for large vessel occlusion, and these can be found on strokeassociation.org under the EMS resources and strokevan.com. So we have a number of emergent large vessel occlusion screens. There is RACE, the Rapid Arterial Occlusion Evaluation Scale. There is legs, eyes, and gaze and speech. There is LAMS, the Los Angeles Motor Scale, the hemiparesis, VAN, which is vision, aphasia, and neglect, the 3-item stroke scale, and then there is the Cincinnati Pre-Hospital Stroke Severity Scale. So there's a lot of large vessel screens that we can use, and they all vary based on the need to calculate the score and then also the number of tests. And the other thing that we can look at when we're evaluating these scores and which one is going to work best for our ED teams, our EMS agencies, and our region is when we look at positive predictive value, and that is the subject that has a positive screen truly has the disease, and also the sensitivity, looking for true positives, and then also comparing all of these screens for negative predictive values, looking at if the subject has a negative screen that they truly do not have the disease, and then also for specificity, meaning that they also have a true negative. So these are the things that we have to look at, and this takes a lot of discussion within your hospital teams, but then also in your region. So we can go ahead and go to the next screen. So we get to our first polling screen. So if you have had a chance to have this level of discussions, then we would like to know from you, what large vessel screen do you currently use? Do you use RACE? Do you use VAN? Do you use something other, or are you using none of the above?
Michelle, I just closed the poll, and it looks like, give me just 1 second while it pulls up. You have, out of 116 participants, 4 that use the RACE, 16 that use VAN, 21 that use other, and 7 that use none of the above.
Okay, great. And really, at this time, there is no standards that are set by the American Heart or the American Stroke Association that use one tool over the other. So it really is a preference of the stroke team as to which tool that you may use. And then you just have to evaluate that tool and see how accurate it is and how well it works for your team. So we can move on to the next slide. So what we do know is reduced time from symptom onset to reperfusion with endovascular therapies is highly associated with better clinical outcomes. So early identification of large vessel occlusion or severe stroke will expedite triage and also transfer to comprehensive stroke centers for more advanced care. So it is important that you do look at a screen and then pick one and then continue to monitor that and see how well it's working for you.
All right, so now that we've looked at some of the different types of stroke and determined we may need to transfer them, it's time to look at what do we need to do in our transferring protocols and guidelines. So what you want to do is establish some handoff protocols and procedures that will provide a safe and efficient patient care between your transferring facility to the receiving facility. You want to establish these protocols early. I can't stress how important that is, so that it can be accomplished at all hours of the day or night. The time to figure it out isn't during a transfer, and that's how mistakes are happening and things get forgotten. So it's really important to look at these early. For primary stroke centers, or even those that aren't primary but having to transfer, it may be important to develop the capability to perform emergency invasive intracranial vascular imaging, such as CT, CT angio, or CT perfusion on appropriately selected patients. To determine the need for transferring, of course, especially for endovascular, it's really important to have something like a screening tool, as Michelle was talking about, for these large vessel occlusions and identifying that population. And the reason we want to do this is, again, to prevent delays in patient care, and you want to establish these at the same time you're kind of looking at a patient for TPA. You want to be looking at the same for LVOs. Let's see, so it looks like we have another polling question, if you guys want to take a minute and answer that.
All right, give me 1 second while it pulls up the. Okay, so out of 118, 2 are CT, 47 are CT and CTA, 26 are CT, CTA, and CTP, and we didn't have any that we're not sure.
Okay, all right. So that's a good number. Quite a few are doing a CT and a CTA, which is, you know, that CTA is going to be golden in determining whether you've got a large vessel occlusion or not. So, and a lot of it depends, too, on if your facility has the capability or not to perform these images. So when you're developing your transfer protocol, some of the key items to keep in mind are to be consistent. You know, use one protocol. Anytime you deviate from this, it leads to disaster. You want to educate your staff to use this consistently regarding the process. And then it needs to be met 24/7. You know, stroke coordinators, we're not there 24/7, and so the things that we teach them are what they have to depend on when we're not there. You also want to include your critical care transfer team or your EMS agencies in your planning and education. They may already have some things, you know, that they're doing and can share with you, but you need to really take a look at them and get their input as well. It's important also to send the documentation and the information with the patient at the time of transfer. Some facilities, I know, sometimes will fax it and things like that, but suppose that your flight crew, your transferring agency have a question about the patient and they've got the chart right there where they're able to go back and look at it. Things that you want to include in that documentation are going to be the time of arrival, the time last known well, any allergies, what were their presenting signs and symptoms, the medical history, any medications, any new medications you've given them, you know, what was their initial NIH stroke scale. If they've received IV TPA or alteplase, you want to review the NIH stroke scale and vital signs that they had prior to administration, the dose that you gave, including when was the bolus, if it's completed or not, and the initiation of the infusion and if it's completed or if it's still infusing. Then, of course, you want to report to them where you are in your grueling every 15 minutes, 30-minute type vital signs and where they need to start the next set with your TPA administration. We talked about the dose, the time was completed, where you are on those two, whether you've completed them or not. And the most important, of course, is to include that 50 cc normal saline flush. So if your infusion is still running and that you know that during transfer, the transfer team is going to be running out, you want to make sure that they've got that 50 cc flush and that they need to document the administration of that. And as we mentioned, we're talking a lot about the ischemic strokes, but for other types of strokes, you want to also include intracerebral hemorrhages, your large vessel occlusions, and things like that. You want to also include the vital signs because every stroke has specific blood pressure parameters that need to be followed. Any medications or interventions that you did, you know, just a nice complete S-bar. Upon arrival at the transferring agency by the at the sending facility, you have the primary nurse give the patient report to the team. Make sure that you've got the paperwork, all completed and that your MOT is filled out, and you want to make sure that you hand that over to them. And these are just some examples of some paperwork. The one is one that we have with our transferring agency. It's just a nice piece that they can actually document on if need be. And then the other one is more of a narrative, but it's really good and goes over the important things like controlling blood pressure and kind of gives a good education on things to consider for your transferring agency. The other forms, and the other form we said was just the narrative that we go over, you know, things that you may do specifically at your facility. Patients should be transferred by a critical care transport team. You want to make sure that you've reviewed their protocols and things like that, that they are able to transfer the type of patient that you're doing. You also want to document the vital signs prior to the departure. Like I said, make sure and let them know when your last set was and where theirs should begin. And verify that they know to keep that systolic blood pressure less than 180 and diastolic less than 105, and specifically for a TPA patient. And then if it goes above those limits, you know, what should that sending hospital initiate? Do they need to start blood pressure control, things like that, and continue that continuity of care with your EMS transport facility? And we talked about verifying the dose and time that TPA was given with them and where you are at in your completion of those medications. And again, stress the importance to monitor and document the vital signs and neuroassessments every 15 minutes. So during your survey, it seems like this is a big deal, they're going to ask you if you worked with your transferring agency on your protocols and guidelines. Remember to review their protocols with that agency. In most cases, they do not work under the hospital's medical control, and a lot of nurses don't realize that. They think that our transferring EMS agencies may follow the same guidelines that they do, but they work under their own medical control. So you want to make sure that they've got the education, the knowledge to transport your patients if they're on TPA, a cardine drip, or any other medications that you use. And it's also important to find out what is their protocol, what medications do they carry. I know one, it was interesting enough, their treatment for blood pressure was nitro. So, you know, look at what do they use for treating your patients. Again, provide a brief but thorough report to the transferring agency. Make sure all your copies are made prior to arrival. You don't want to delay making copies while the flight team or whoever is there transferring your patient. That's just going to cause a delay. So make sure, and also a thing is they're kind of timed on their time on scene. So they're under the gun to get that patient out, and it is important for that patient. So time's a really big factor there. So you want to include any acute worsening or neurological conditions that may develop with a patient. Did they get a new headache? Any acute hypertension? Are they nauseated, vomiting? And what about angioedema? That's a really important one. Very rarely does it happen, but the time when it does happen, you need to have all this figured out ahead of time. So that's something, again, that you want to make sure that your flight crew or your transferring agency is able to handle treating angioedema. And again, go over your guidelines for your TPA patient, or if it's another type of stroke, such as a intracerebral hemorrhage, LVO, review the blood pressure parameters again and your treatment with them, and make sure that they have what they need to treat those patients. If your transferring agency is trained on them, but they don't carry the medication, sometimes we've actually sent the medication with them just in case they need it. I know one example of that is that 50 cc normal saline for the flush, and then sometimes cardine.
Once the patient has arrived at the Comprehensive Stroke Center, the receiving RN then must assure that they receive the documentation and information that Jamie has reviewed. So that really puts a lot of ownership on the receiving RN and the receiving facility to not only receive the information, but to also ask for that information. So the surveyor will definitely hold the receiving facility ultimately responsible for ensuring that all of this information does make it into the patient's record so that we can show that there is continuity of care. So we will need to end up with all of the ED documentation from the sending facility. We definitely need to be capturing the time of the TPA bolus, all of the vital signs. They will also look to make sure that these vital signs are within parameters and we do need to follow up with the sending facility and or the EMS transferring agency for follow-up if we find that there are some opportunities there. And they will also specifically look for this 50 cc normal saline flush. That is definitely a high priority right now on all of the surveys. Also, we talked about getting a copy of the monitoring and treatment that's been provided during transport from the transfer agency. Oftentimes, their documentation is electronic, so they may not have a copy of their full run sheet to provide to you at the time, but they can provide you a code summary, so the receiving RN can ask that they print off a code summary from the monitor that the patient's been on, and that will give you a run of the cardiac strip along with the blood pressures that have occurred during transport. And then oftentimes the stroke coordinator or stroke director of the program then will have to go back, preferably within 24 hours or as soon as possible, and get a copy of the run sheet then to place into the medical record so that we can close the loop and have all of the documentation in the patient's medical record, especially since we know that this is something that the surveyors will look for each component to be present in the medical record. So we have another polling question. So we'd like to know who currently has protocols in place that addresses all of these aspects for the sending facility, the transferring agency, and also the receiving facility.
Okay, so out of 122, 38 said yes, they have it, and 21 say they do not have it.
Great, right. So that's just a big opportunity for, I think, all of us, is to just really make sure that we are closing the loop. We all affect each other, and so it just requires a lot of work and a lot of consistent focus on the transition of care for these patients. Our ultimate goal is to keep these patients safe as we're moving them from point A to point B.
So now we've come down to performance improvement, and I know as stroke coordinators, this is a huge part of what keeps us busy, but this is where we close the loop in our patient care. As a stroke coordinator, it's important and a vital step to make sure your program is providing patients the care they need to maximize their outcomes. Hospitals should review and monitor stroke care benchmarks, indicators, evidence-based practices, and outcomes timely. And I even stress, if it's possible, to try and do a lot of this concurrently, maybe the day after or whatnot, look at it, because that's the best time to review things with your staff. You've got a better chance of catching them there. If you wait a couple, 2-3 weeks, you know, it may be a while before someone's back on shift, and they pretty much forgot about what happened then. So I can't stress the importance of trying to review these concurrently. PI feedback is valuable for the success of your program. You have to include the good and the bad, and you've got to have some of those difficult conversations, but you really can't fix what you don't know. So it's important that everyone gives good and bad feedback to each other. Communication is the key in providing future patient care safe and efficiently. Be sure to review your PI data, fallouts, and kudos with your staff. And you also want to talk to your transferring agency. If it's a sending facility, you want to talk to your transferring agency and even your receiving facility and make sure that they got the paperwork that was needed. And I think Michelle will speak to what happens on the receiving end, but I think they're actually the one responsible for making sure they received everything from the sending to the transferring agency to their facility. So, but PI is very important, not just in transferring of patients, but for everything you do as a stroke coordinator in your program. And probably none of us can collect too much data. And as a survey, they always ask you, you know, what are your new PI initiatives? So something like this might be a great one to show what you've done as well.
So performance improvement is all about improving patient care outcomes, and it does require continuous quality improvement processes, and the more timely the better. And each major element of stroke system of care must be involved in that. And so one thing that we definitely know is that what happens today becomes the past, and it shows up in the future. and everything is linked. And so every point, every step in the process affects every other step in the process. So every goal that we're trying to reach actually impacts the next goal that we're trying to reach. So when we're looking at door-to-needle times, they now become even more so important. So when we're talking about getting door-to-needle times within 45 minutes and within 60 minutes, they now are going to impact door-in, door-out times at a primary center, because now we're trying to not only achieve door-to-needle times for IV TPA, but we're also trying to achieve getting someone transferred to a comprehensive center for possible intervention. So door-to-needle times now become ever more important. We're also looking at transfer times, so door-in, door-out times, but then also transfer times to a comprehensive center. When we're looking at transfer times to a comprehensive center, we're looking at the time that that individual walked in the door at a primary center to the time that they're now entering the door at a comprehensive center. So we've kind of set that marker at 2 hours, but that mark is now getting much shorter. So really preferably within an hour and a half, and I think those times are going to get a lot tighter. So every time we are moving one of these patients, these are the numbers that we need to go back and look at and see what's happening with each one of these goals and how are they impacting the next goal that occurs beyond that. When we're looking at door-to-groin puncture, we also need to take that into consideration. We're not just looking at door-to-groin puncture, comprehensive door-to-groin puncture. We are actually looking at primary door time to actual groin puncture. And so sometimes that can be a lot of time because the patient gets hung up at the primary center before we're actually able to get them into the comprehensive center and then actually to groin puncture. And so there's a lot that has to happen with aligning transfer and actually moving the patient. The most important thing, though, is keeping that patient safe as we transfer them. So the transfer not only has to be efficient, it also has to be safe. So we have to look at things like intervention. So first of all, are we triaging these patients effectively? Are we selecting and choosing the right patients for intervention? So when we're moving them, are they actually the ones that actually qualified for intervention? How well are we doing with our large vessel screen so that we're utilizing our resources effectively? Then we have to look at complications. How good are we doing with our transfer guidelines? When we look at blood pressure management, are we having hemorrhagic transformations after TPA? Are we doing a good job with blood pressure management from the sending facility throughout transfer and then also once they arrive at the comprehensive center? That's our biggest opportunity to try to prevent hemorrhagic transformation in many of these patients. So we have to really treat these patients very safely, even though we are trying to transfer them very quickly. And then ultimately, we have to look at disposition of these patients. So we want to know, do they go home? Do they go to rehab? And what are they like functionally? Are we able to return these individuals back to their previous state of living, or at least to a state of functional independence? And so this requires a lot of communication between each stroke system of care. So you can go ahead and go to the next slide, Jamie. And so there are a number of ways to communicate amongst all of these, amongst all of our teams. And I found that the most effective way to do this is by sharing different cases. And one way to build is to share great cases initially. Sharing good stories gets the team engaged. It gets people really excited about what it is that we're doing and why we are doing this. And so this is one example. You can do posters on case reports. This is an example of a de-identified case presentation. You can take these out to your EMS teams. You can share these at meetings. You can post these in your EMS department, your ED departments. You can share these. It includes a timeline. And these are great stories to share, and people get really excited about what's going on. And as you open these lines of communication, then it becomes a lot easier than when you then begin to face challenges and more difficult conversations to say, okay, well, what do we now need to fix? Because it's not just always discussing bad news. You have some great cases too. Another format, you can go to the next slide, is also using case feedback letters. These can get a little bit more in-depth. I like to include a little bit more complicated or more in-depth information. I send these in a more protected format so that you can include some specific information so that the teams, physicians, stroke directors, and coordinators can then actually dig back into cases and look at specifics so that they can use these for performance improvement. We can share images, we can share images before and after and perfusion images, and once again the timeline, focusing on how quick did TPA happen, how quick did your transport arrive and depart from your facility, how quick did they get over to the comprehensive center, and these are the things that we need to focus on. And once again, these feedback letters happen when cases go great. Those are the letters I think that we need to always send, and then that way I think we're always more receptive than when we have a case that we actually maybe need to pick up the phone, or a case where we need to send a letter and say, I need you to pay special attention to this component and please round back to your team. You can go to the next slide. Another way to have good conversations is through a regional performance improvement committee. Our team happens to meet monthly. I think it's good for traction to have routine meetings. Good to have conversations between region hospitals, EMS, and transport agencies. Transfer of patients is not about one hospital. It's not even about a hospital system. It's an entire regional effort. So that is one thing that I definitely have learned over trying to work out transfer guidelines, is that it's the entire region that you're in. Our region has a format where you can actually put in cases for review. So when you have challenges that are related to transfers, we can actually put in case reviews for request, and then we can discuss these as a team and decide what can we do as a region to try to improve the transfer of these patients. We've come a long way, and we will actually be submitting some information on some improvements in both outcomes and also transfer guidelines to the stroke conference that's coming up. So we've made a lot of gain just through this work that we've done. You can go through the next slide. So, you know, I think that we focused a lot on what can we do to safely transfer our ischemic stroke patients that have had TPA and those that are going to be transferred for endovascular intervention. And we're really being challenged by our surveyors actually to do this for the right reasons. It's for patient outcomes. If you have not already thought about it, though, I think that the next steps are to do the exact same things for what's happening with our intracranial hemorrhage patients and our subarachnoid hemorrhage patients. So I think we'll soon be looking at regional protocols for reversal strategies. We'll need to know which hospitals actually have reversal agents on board, and we'll need to be looking at similar timelines if you're not already looking at them. When you're looking at arrival to door-in times, how quick are you getting your PT-INRs? Most of us are already looking at that, but are you actually looking at how quick are you getting a door-to-reversal agent? And then if that patient is being transferred for a higher level of care, how quick is that patient getting out? And then we have a comprehensive door-in time and then a PT-INR goal. So I think that's something that we'll have to look at next. We know how surveyors work. They're going to make sure that we nail down the transfer of a TPA endovascular patient, and then they're going to begin to dig deeper and challenge us further. We can look at the next slide. And then with that, we'll also have transfer guidelines for hemorrhagic stroke. So much like we're talking about with these blood pressure parameters, we're going to have to do the same for our subarachnoid and intracranial hemorrhage patients. Our surveyors are going to hold us accountable for keeping our stroke patients safe, and we will have to work with our transfer agencies. And we also, if you are receiving patients, then you have to have relationships with the hospitals that are sending you patients, and if you are sending patients, then you need to have relationships with who is transferring your patients and who you're sending those patients to. So we all have to develop these parameters for management of blood pressure, and as Jamie said, we need a consistent protocol that we use throughout the region, and we'll need to develop these protocols. Same thing that hit all of us, the transferring facilities, the transferring agencies, and the receiving facilities. So I already know a fellow colleague that really looked at this within her hospital that looked at arrival to door-in times and initial blood pressures for hemorrhagic strokes, door to antihypertensive, a blood pressure goal then that was reached. If you are transferring, then once again, you have a door out, a comprehensive time, and a blood pressure goal. So I think as we're thinking about all of our different stroke types, we need to basically have a mirror image regardless of stroke type. We need to be looking at time-sensitive treatments. We need to mirror our algorithms and understand that we need to safely transfer these patients. We need to be efficient, but we need to do it safely, and we're all in this together. I think that's the most important thing, so open lines of communication are what are going to get us there. So I think we can go to our next slide. So Jamie and I are both open for questions and comments, and I know that we both thank you for your time and definitely your attention, and we both hope that this has been helpful.
Hi, Michelle. I do have some questions on the WebEx. The first question is, does a RN go with your drip and ship patients from a PCP to a CSC?
This can vary by region. I just visited a comprehensive stroke center that was in a different region, and their model did include an RN that transferred with the patient from the primary facility over to the comprehensive facility. So that was within their model of care. Within our region, we do not have that model of care, so we are definitely reliant on ensuring that our transfer agency, we only use a critical transport. We are very reliant on the education and the expertise of that transfer agency to ensure safe transfer. So we do a lot of process improvement, a lot of two-way communication to make sure that our goals are met while that patient is in their care.
Thank you. And the other question is, can the letter and the poster templates you shared be shared with the group?
Absolutely, yes. I can get that template out.
Perfect. And if anyone would like to actually ask a question, you can unmute your line by pressing *6, or you can type in the Q&A section. We've got another question. Are you seeing TJC and DNV looking at the 2018 guideline updates for LVO? We just received our training from our telemedicine program and have our survey in August. Are they looking at these for non-conformity?
They are, I don't think they're giving out nonconformities just yet. However, they are looking and expecting to see that you are moving forward with things such as 24-hour stroke alerts. They are looking to see that you are incorporating LVO screens or a process to triage your patients for LVO, and they're definitely looking to see that you are including documentation for endovascular intervention for those patients that now do go out to the 24-hour window. So they are being very critical and thorough and looking for that level of documentation. I have not seen an RFI for that yet. I've seen a couple of people and seen a couple of conversations of some surveys that have happened. The conversations are definitely there. I haven't seen the RFIs go out for it yet.
Thank you. Are there any other questions? Again, you can *6 to unmute or type in the Q&A section of WebEx. Okay, at this time, if there are no more questions, Jamie, Michelle, thank you both so much for a great presentation. And also for those that participated, just a reminder that today's slides and any handouts that Michelle will be sending us will be provided to you within a week of today's call. You can also claim your CME CE credits at the end of the 15-week series on September 27th. Thank you. Thank you so much again for everyone's attention and participation. Goodbye. Thank you. Oh, Jamie?
Okay, that is the worst presentation I've ever done.
Is this a practice run?
No, it was the actual presentation. Oh, God, I felt I tanked at the very beginning there. Like, oh, my God, it was horrible. Oh, I just felt like my nerves got me at the beginning, and I just, oh, my God.
You sounded perfect.
I'm just going to go in the bathroom and cry.